Your patient's crashing, the gas looks terrible, but is it oxygenation or ventilation? If you don't know the difference, you'll treat the wrong problem and they won't make it. Oxygenation is about oxygen getting in. Ventilation is about carbon dioxide getting out. Think of it like this. Ventilation is like bellows. It's moving of gas. Oxygenation is like a filter. This is gas exchange, and it happens at the level of the alveoli. You can pump the bellows perfectly, but if the filter is waterlogged, oxygen won't cross. Or the filter can be fine, but if the bellows barely move, carbon dioxide builds up. Oxygenation is measured by SpO2, which is the finger monitor, or rarely the PaO2 on an ABG. So how do we fix it? Start with your fraction of inspired oxygen. This increases the oxygen concentration you're delivering. And more oxygen in the alveoli gives you a bigger gradient, meaning more diffusion. You can also adjust the PEEP, which is your positive end expiratory pressure. This prevents alveolar collapse. It recruits atelectatic units, pushes fluid out of the alveoli, or spreads it evenly and thinly in ARDS. And so you have more surface area open and more oxygen can cross. So think it's keeping the alveoli from snapping shut after each breath. So FiO2 means that there's more oxygen available, and then your PEEP is going to be more alveoli available to use it. This is commonly happening in your ARDS patients, your pneumonia, pulmonary edema, where the lungs are wet or injured, and this is just destroying the diffusion capacity at the level of the alveoli. Now, ventilation is measured by your PaCO2 and your pH on your VBG, right? Carbon dioxide clearance depends on minute ventilation, which is tidal volume times respiratory rate. And how do we fix this? So tidal volume. So bigger breaths equals more alveolar ventilation and more CO2 removal. It's limited by lung protective strategies. You're maxing out really around 6 milligrams per kilogram ideal body weight in ARDS. And then respiratory rates is also something you can adjust. So this is more breaths per minute. So just by nature of that, you have more CO2 clearance. Watch for autopeep and obstructive diseases like COPD and asthma. So tidal volume is like the size of the bellows stroke, and then respiratory rate is how many strokes per minute. Together, they set how much carbon dioxide gets blown off. So these patients I like to think of in two different groups. So your COPD and asthma patients are basically creating a tight passage and flow rates are lower with a small diameter, or you might have globally reduced function from something like apnea and opioid overdose or neuromuscular weakness. And here's a pearl. If your oxygen is low, but your CO2 is normal, you've got an oxygenation issue. If your CO2 is high and your patient's acidotic, you've got a ventilation issue. I've always been confused about how they don't just exist together, and I think this is so important. Carbon dioxide diffuses 20 times more easily than oxygen across the alveolar capillary membrane. So even if the alveoli are inflamed or thickened, it's pneumonia or ARDS or something like that, or partly filled with fluid, carbon dioxide usually still crosses into blood and gets exhaled. Oxygen, by contrast, has a harder time crossing in those same conditions, and hypoxemia happens first, while CO2 in that situation remains normal. Confuse oxygen and ventilation, and you'll chase the wrong problem. Save this, because next time you're bagging a crashing patient, you'll need to know which knob to turn.